In this phaco cataract basics and advanced course part 3, that is, we are going to discuss in today's lecture wound construction, closure, capsular rhexis and hydrodissection techniques. And in previous 2 lectures, we have discussed phaco and with the name of Know Your Machine. And then we discussed how to minimize surgeon-induced errors and role of non-dominant hand in phaco-cataract surgery. And we are going to build upon it with wound construction, closure, capsular rhexis and hydrodissection techniques. जलता सूरज तनकर बोला कोई ना रोशन मुझसा हो। जलता सूरज तनकर बोला कोई ना रोशन मुझसा हो। धीमी लो का एक चिराग बोला शाम उतरने दो। We have divided today's discussion in 3 parts. Section 1 is wound construction and closure. Section 2 is capsular rhexis techniques. And section 3 is hydrodissection and hydrodelineation techniques. And you are going to enjoy the story of forbidden love, that is Ishq-e Mamnua or forbidden tree, Shajre Mamnua, between these 3 sections of the presentation. So this is how the story starts, with the concept of solar system, Nizam-e Shamsi. मैं मज़हर हूँ मेरे अपने सितारे हैं कमर भी है। मैं मज़हर हूँ मेरे अपने सितारे हैं कमर भी है, मगर ये भी तो देखो ना कि दिल भी है नज़र भी है। So it's kind of Nizam-e Shamsi or solar system with its own moon and its own stars around it and own galaxies. मगर ये भी तो देखो ना कि दिल भी है नज़र भी है। मेरा अपना महवर है तुम्हारा है मदार अपना। I have my own orbit and you have your own axis of rotation. मेरा अपना महवर है तुम्हारा है मदार अपना, गर्दश पे मुकद्दर की नहीं है इख्तियार अपना. And all these stars and galaxies and the moon and the sun are rotating in their own orbits, so one cannot meet the other. This is kind of the helplessness of the poet. मेरा अपना महवर है तुम्हारा है मदार अपना, गर्दश पे मुकद्दर की नहीं है इख्तियार अपना. So these are the first 2 verses of that story of forbidden love, Ishq-e Mamnua, and we will keep on touching this in between the presentation. So here we come with the section 1, that is wound closure, wound construction and closure. You see, the location of the incisions is important. Mostly you may have already observed the surgeons prefer superior location. It has got its own advantages. It is covered by the eyelids and it's easy for the beginners. Disadvantages include it's relatively difficult to, especially in oriental eyes which are sunken and deep set. Because of the high brow, sometimes it becomes really difficult to construct these incisions properly. then there is less red glow, because during most of the maneuvers, the eye is a little rotated inferiorly, which makes it less likely to have good fundal glow. And then, because especially the phaco probe, is straight. So if you have constructed your incision superiorly, it is always difficult to enter into the anterior chamber without distorting or without again inferiorly rotating the eye, especially in deep set eyes, which most of our nation has. Oriental eyes are generally deep set with high orbital arcs. So these are the disadvantages of superiorly located incisions. The other option is to place your incisions in temporal location, that is between 11 and 1 o'clock. It's easy generally, and the other advantage is that the wide to wide diameter is more in horizontal axis as compared to vertical axis. So that makes this incision relatively away from the center. The further your incision is from the center of the visual axis or corneal apex, the lesser astigmatism you are going to induce. So that's an advantage. Second, because the eye is open and there is no brow over there, so your hand and your approach becomes much more easier. While passing your keratome, the recommendation is that it has to be angled in 30 degrees inferiorly as compared to tangent to the limbus. Then the really symmetrical incision is constructed, and that entry is more easily possible once you are placing it at the temporal part. So there are many disadvantages in temporal incisions. The disadvantage, it is not covered by the lids and relatively exposed, and if it is not closed well at the end of the surgery, there may be theoretically more risk of contamination of the wound. 2, you have to change positions. As we discussed in our previous talk, role of non-dominant hand in phaco cataract surgery. If we are not very well versed with use of both hands to place incisions and to handle the instruments and phaco probe, then to construct and to perform surgery through temporal approach will need to rotate your positions. That is generally cumbersome, that you have to sit temporarily and leave the head side, which most of us are used to. So this is a kind of relative disadvantage. Then the discussion comes over whether it's clear corneal incision or scleral incision. The rule is, the further you are from the center of the corneal apex or visual axis, the lesser you induce astigmatism. The second thing is, there is a disadvantage of clear corneal incision, that it will not heal with that strength as an incision in the vascular part will heal. So even if you are in favor of clear corneal incisions, you will see in later slides that the recommendation is that to place it as far peripheral as possible, so that there are a little spots and twigs of bleeding from limbal capillaries once you are placing the incision. That is very helpful. That leakage of blood and that little distortion of limbal cutting of limbal vasculature is going to impart very good, quick and strong healing response from the limbal area. So clear corneal incisions, easy to perform, avascular, but they can induce more astigmatism and they are weaker in strength as compared to posterior limbal or scleral incisions. So the best way or the in-between way where you can have the easiness of corneal approach combined with good healing is posterior limbal incision, just touching the limbal capillaries. So there are 3 rules which I found during my search of internet, and these are by Uday Devgan. He is one of the best phaco cataract coaches around the world. The rule 1 is, why these rules are important? Because a poorly constructed corneal incision could put the patient at higher risk of complications. So rule 1 is stay peripheral. A corneal incision that nicks the limbal vessels will seal securely and return to a high level of strength. Rule 2 is make the incision symmetric. The thickness and the shape of the incision. The thickness means that the roof and the floor of the incision should be equal in thickness. And how can you achieve that goal? Is by passing your keratome a little depressed towards, not parallel to the iris, but directed towards the center of the cornea initially. And in the end, you can just raise your arm and enter into the anterior chamber to make it 2-step or 3-step incision. But the main passage through the corneal stroma should not be directed parallel to the iris, should be directed towards the apex of the cornea. That will make the roof and floor of the incision equal in depth. Shape of the incision. As we know, the incisions which are parallel to the limbus induce more astigmatism. The straight incisions induce less astigmatism, and the frowning incisions induce even less astigmatism. So general preference would be, because we use keratomes, that we place the keratome in proper position and keep a good direction throughout the incision and keep the eye stable, and the angle of entry into the corneal stroma is very important. The third rule is keep the incision architecture consistent. So that is concerned with tunnel length and direction. If due to some reason, because of the bluntness of the keratome or because of the initial learning curve, if we make our incisions oblique, they are not that good to seal and not well controlled in terms of postoperative surgeon-induced astigmatism. The incision the entry has to be radial and straight into the cornea. And the tunnel depth is very important. Generally speaking, 2 to 3 millimeter depth is required, and the incision needs to be either rectangular in shape or square shaped. The more squarish your incision is, that the width and the depth of the incision are equal to each other, the more chances are that you will be secure and easy to seal and better to heal and with less surgeon-induced astigmatism postoperatively. So these are the three rules. We will elaborate it further in the coming slides. You see the rule 1, the corneal incision should be placed generally at temporal limbus with care taken to avoid purely avascular anterior incisions. Temporal incisions are better because you will be further from the corneal center and the lesser the astigmatism induced. And then you have to touch the twigs of the limbal vessels so that there is good healing and strong scar postoperatively, because the clear corneal incisions have been noted to give way even months after the surgery very easily. Their strength is not optimal. So as you can see, this is a beautiful incision which is placed at 180-degree axis, and it is rectangular in shape, 2 to 3 millimeters in depth and about 2.75 millimeters in width, which gives rise to good long-term sealing. It is further from visual axis and will give rise to lesser astigmatic effect. Poor form of incision is depicted in the lower diagram. As you can see, the clear corneal incision will be weaker in long-term healing. Being close to visual axis will induce more distortions and is prone to induce more endothelial damage as well. And it will give rise to more surgeon-induced astigmatic effect postoperatively. So this was rule 1, stay peripheral. The rule 2 is make your incisions symmetric. Incision with good form has symmetry between the roof and the floor, compared with one poor form that is asymmetric and can show chevron effect, which is kind of irregularity in the outer and inner lips of the incision. In good form, it will be equal thickness in roof and in floor. And you see the direction of the incision is directed towards the apex of the cornea. It is not parallel to the iris. So that gives it better thickness, and the roof of the incision is equal to the floor of the incision in thickness. So that's the ideal incision. And in poor form, you may enter parallel to the iris, and there may be chevron effect, in which the tip of the keratome and the rest of the blade are entering into the endothelial side of the incision, inner side of the cornea, at different levels. And it is a kind of incision with a notch, with a tongue. So that's not a good incision to seal. And if you just follow one simple rule, that depress your handle of your knife so that you enter into the cornea at almost 30 degrees to the tangent and limbus, you can achieve this goal of having beautifully symmetric, well-sealing, strong incision near to the vascular, as near to the vascular limbus as possible, without distorting the conjunctival architecture. So the rule 2 is make the incision symmetric. The rule 3 is keep the incision architecture consistent. The entry should be radial, not oblique. Oblique is due to some reason you tilt your keratome a little bit. Either you are entering like this or you are entering like this. Radial is just straight to the limbus, you are entering straight and angled at 30 degrees. That the cut which is finally placed is straight tangent to the limbus. It is not oblique. That is one thing. And it also gives rise to proper tunnel dissection and good healing postoperatively. You see in the diagram, this is a straight passage keratome is entering straight into the corneal stroma, and in poor form, here is the oblique passage that the keratome is directed either right ways or left ways while entering into the cornea. And I share a good news here again with you that these PowerPoint slides in PDF form and in pure presentation form will be available to you to download. And the slides and the video you may have already enjoyed are also available on onlinesummit.org, and we generally share the YouTube link by the same evening with you people. So there is nothing to worry, there is no need to take the snaps. All the material will be available to you and our all international audience around the world in the shape of PowerPoint slides, PDF form, and in slides and video webinar form. And you are welcome for any questions and comments on any of the forums available, including WhatsApp or onlinesummit.org comments place or YouTube comments place. Whenever you will come up with a query, I'll be very glad to answer and have even one-to-one chat with any of the interested colleagues and residents. So these three rules are kind of gist of incision construction and giving safety to the eyes of the patients. Astigmatic considerations we have already discussed. Site of incision, superior incisions are more prone to induce astigmatism as compared to temporal incisions. Then with good tunnel length and by placing the incision further from the center of the cornea, you can reduce surgeon-induced astigmatism. And surgeon-induced errors, in our previous discussion, there was a lot of stress and clear guidelines we had about construction and minimization of surgeon-induced errors. So this was about astigmatic considerations, and due to some odd reason, we have gone a little, there is a little glitch. Let me fix it. Meanwhile, we can have some questions so that I keep on talking and our international audience don't feel. आप इसका अडॉप्टर दीजिए मुझे HDMI. It's coming. दूसरा कर लो। So we are back. Astigmatic considerations we have discussed. Then the incision size need to be optimal in coherence with the phaco tip as well. Because if the incision is too tight, it will just compress your sleeve and the irrigation line will be bothered and there will be more chances of anterior chamber collapse and phaco burn because the less fluid will pass. And if the incision is too wide as compared to size of your phaco tip, even then there will be excessive leakage of the fluid. As we discussed in phaco-dynamics, that the ideal scenario is in phacoemulsification cataract surgery that the ingress and egress, influx and outflux of the fluid from inside of the anterior chamber is all controlled by phaco, so that all the chips and the sensors keep on working in your favor. If your incision is too tight or too loose, then the phaco may not be able to read, the phaco software may not be able to read the anterior chamber fluidics properly, and you may end up with chewing of iris or corneal burn. So it has to match with the phaco tip, the sleeve size you are going to use. As you can see, the incision parameters, the location can be circumferential, radial, superior, temporal. And then the location is whether it is circumferential incision or radial incision. The 3D architecture is very important. The 3-step incisions are better than straight single-step incisions. Incision location, as we discussed already, has to be placed either superiorly, supratemporally, or temporally. This is the direction. The keratome needs to be directed right through the center of the cavity. The width and the is very important, and while entering the keratome, it has to be directed angled at 30 degrees. The size of the ideal incision is plus minus 3 millimeters, and the maximum size we can have is 5 to 6 millimeters. The longer the size, the further you need to be from the visual axis. And the incision, if you are going to place a scleral incision or a bigger incision, then better to construct a funnel so that the scleral part is longer than the wider than the corneal part. And as we discussed already, the location and the size of the incision is very important once you are handling with the phaco probe. As you see, the keratome goes straight, and here you notice the direction of the keratome is to the apex of the cornea, not parallel to the iris, and a beautiful rectangular incision is constructed. And here, because the surgeon wanted to move more posteriorly, he has performed a conjunctival peritomy, which is not my preference at least. See the direction again. It is towards the corneal apex, not parallel to the iris. And this is the width and the depth of incision, and these are the steps, which is known as 3-step incision. Again, beautifully constructed incision with 3 millimeter width and about 2+ millimeters depth. And the roof and the incision and the floor of the incisions are equal in depth. Let me play this video for you again because it is very important. Due to some reason, the Mac speakers are disallowed during the webinar. So once you review on net, the video will be there with voice and you will get better elaboration. But all the points I have already stressed. The direction of the keratome while entering into the eye is very important. With that, we come to Capsular Rhexis part 2 and again part 2 of the Ishq Mamnu as well. मैं मज़हर हूँ, मेरे अपने सितारे हैं, कमर भी है, मगर ये भी तो देखो ना कि दिल भी है, नज़र भी है. मेरे अपने सितारे हैं, कमर भी है, मगर ये भी तो देखो ना कि दिल भी है, नज़र भी है. न तुमने हौसला बख्शा, न मैंने ही जसारत की. न तुमने हौसला बख्शा, न मैंने ही जसारत की. न कुछ बोले कनायों में, न नज़रों से शरारत की. न मैंने पेशकदमी की, न तुमने की पजीराई. न मैंने पेशकदमी की, न तुमने की पजीराई. न निकली आह सीने से, न पलकों पे नमी आई. But as usual, we have few glitches. So we are back to action, hopefully. Good. न मैंने पेशकदमी की, न तुमने की पसीराई. सीने से न पलकों पे नमी आई. So the story started from मैं मज़हर हूँ, मेरे अपने सितारे हैं, कमर भी है, मगर ये भी तो देखो ना कि दिल भी है, नज़र भी है. So now the poet is not able to move any forwards. So central curvilinear capsular axis, that is known as CCC, the most crucial step in phacoemulsification. I have seen the residents talking अल्लाह करे आज मेरा रैक्सिस ठीक हो जाए, फिर फेको दी खैर है. So this is what you need to learn. It is just like, you see how difficult and how delicate is the job. I always give it example of a potato, that you have to, कि आलू का गूदा तो सारा निकाल लेना है. You have to take the whole pulp of the potato out, and you have to preserve the skin of the potato. And you know how fragile is the skin of the potato. Sometimes after a successful phaco surgery of a hard cataract, mature kind of hard potato, I am always just thinking back that how Allah has blessed His men with and skills, that with certain high technology we are able to emulsify the whole cortex and the hard nucleus out, and still the potato skin is there for intraocular lens implantation. So this is how you start addressing the potato now. After placing the incision, knowing your machine and knowing your hands and training your hands with the incisions, now comes the real task, that is continuous curvilinear capsular rhexis. Because in the initial phase of the phaco, once we were doing can opener technique, there were a lot of complications in phaco cataract surgery because of the just simple fact that the rhexis margins were not strong, and they used to come into the phaco port again and again, and were not able to tolerate the fluidics of the phaco machine, were not well tolerated by the anterior chamber, and the more complications were there. So it determines the fate of cataract surgery, requires a lot of practice, and should be circular and correct in size. What is the correct size? About 5 to 6 millimeters. And the rule is that your rhexis need to be about 0.5 to 1 millimeter less than the optical diameter of the lens you are going to implant. So that's the rule you follow once you are aiming for the size of the rhexis. And that means rhexis margins need to override the IOL optic by half to 1. You see, this is the overall size of the optic, and our rhexis is overriding the IOL optic by 0.5 millimeters. This is what our desire is. What are the prerequisites of a good capsular rhexis? Continuous curvilinear capsular rhexis. You have to have clear cornea, well maintained deep anterior chamber. You have to have good quality viscoelastic, a well constructed cystitome, well dilated pupil, good red reflex, or you have stained the capsule for proper visibility, appropriate zoom, and focus on the anterior capsule. I always adjust my focus for capsular rhexis right on the capsule under high magnification. So a good cystitome can be constructed by the help of a good assistant nurse or your assistant or your own self under microscope. The angle of both the angles of bending of the needle need to be about 120 degrees. The tip should not be bent vertically. It should be just angled at 120 degrees, not 90 degrees. Because of 120 degrees gives you more freedom, and there are less chances of entrapping or inadvertently extending the rhexis. So 120 degrees is the ideal bend of the tip as well, and the tip should not be very large. It should be about only half millimeter, just inside the bevel of the needle. Initially we were having for can opener technique large tips, which is not needed because you are just going to use it to drag, you are going to rex it, you are going to tear it. So we will see in the later slide what's the difference between a tear and a can opener technique. And as you see, half of the bevel is bent here in this magnified view. And here it is straight, and here there is, the surgeon has given a little central bend as well. I prefer this above one, just 2 angles. 27 gauge or 30 gauge needle can be used for this purpose. The first objective in Rhexis technique is to raise the flap, a little tongue of the capsule, and then would be that rest of the touches we make, or we pull or we push, are all on that inverted flap or inverted tongue of the capsule. We never touch the bed of the capsule. So 2 bends are generally made in the needle, and this is what I mean by angulation of the anterior segment instruments. These angled instruments are easy to enter even through 12 o'clock incisions, but the straight instruments are difficult to handle and enter into the eye through 12 o'clock incisions. The first bend is generally near the base, and then half of the bevel is bent at 120 degrees to construct a proper cystitome like this. This is what I mean by raising of the tongue. First cut you made with the help of the tip and the bevel of the cystitome, that is radial, about half of the full length or the radius of the capsular rhexis you are going to desire, and then you just pull it and raise this tongue. And once this tongue is raised, then all of your rest of your touches will be on everted surface of this capsular flap, not on the main capsule itself, because that will give you an additional, because sometimes during pushing and pulling of this flap and completion of this rhexis, sometimes even in experienced hands, sometimes you can puncture it. And if your cystitome is handling the capsular bed, then there is a kind of catastrophe can be there. The raised edge is folded back on itself and the flap is made. Then you keep on pushing this flap and you complete the rhexis. If we keep on dragging it 360 degrees, that you will see in the later video, the force is applied at any point along the rhexis tangential to the radial of the rhexis, and generally our force is directed towards the centripetal. The rhexis is steering in tangential direction, but we are pulling the flap towards the center, and this very delicate balance, once we learn it, gives rise to beautiful round well-centered capsular rhexis. And it can be achieved with the help of a needle or a forceps. In forceps case, you have to may need to use viscoelastic, and you have to inject viscoelastic again and again until you are very expert with the forceps use. But if you get used to needle assisted capsular rhexis, then the chamber maintenance becomes relatively easy and you can complete it more easily and without having injection of viscoelastic material multiple times into the anterior chamber. Strength of the rhexis margin depends that it is not cut, but it is torn. With the kind of pull-push forces, we tear it. That tear gives the strength to the capsular margin. And you know, the studies show that we use radio frequency needle as well. With a little heat, we can generate the same round rhexis. That is known as radio frequency needle induced or assisted rhexis. And we can use the femtosecond assisted rhexis as well. But the interesting factor which has come up and which again goes in favor of needle assisted rhexis is that this simple tearing technique of needle or forceps, this rhexis margin carries the highest tensile strength. Even it is better than femto assisted rhexis. So this is the beauty of learning this needle assisted or forceps assisted rhexis, because this gives you the strongest rhexis margin to tolerate well your phaco manipulations.
Sir, what is the reason of this? about फेमटोसाइक्लिक के साथ चलते हैं उसमें वो स्ट्रेंथ नहीं है वो क्या
because the femto also doesn't cut it very regular round, and it uses kind of same technique which you use in tearing papers. It actually creates small cuts and then you join it, so that in itself explains my point. Rhexis was found not that strong margin of the rhexis. But of course femtorhexis has its own advantages. For example, in hypermature cataracts you don't need any staining. So in femtorhexis you can achieve any size with great ease. So there is another machine with the name of Zeptorhexis. That is also a needle which is supplied a little energy by a machine, and you can complete similarly. You just take a round circle, and many Ortley machines are there with this radio frequency needle. You can use all those techniques, but if you are good with needle assisted rhexis, it is matchless. So here is the needle. The first cut we have performed, that is the radial incision. Then we are raising the tongue, the flap, and rest of the touches are being made on anterior surface of the everted surface of the flap. And very gentle and great care is being taken that this needle never touches the capsular bed and remains away from the delicate bed of the capsule. We can see it again. You see, this is the radial incision first, then raising of the flap, eversion of the flap, and then all the rest of the strokes are on the flap margin and away from the margin of the capsule and the bed of the capsule. And in a beautiful manner, simple needle assisted continuous curvilinear round capsular rhexis is generated. The advantage forceps has its own advantages. The people who are good with forceps, they always enjoy it, but better is to be good with both, because once a while if something goes wrong you will need forceps to complete the rhexis, especially in pediatric cases and in hypermature cataracts. You have to have good command with forceps assisted rhexis as well. So first you learn needle assisted rhexis and then you start having good command on forceps assisted rhexis as well. You trata forceps and there will be many names available. Simple McPherson forceps, Utrata forceps, there may be 10 or 20 different names and models which the surgeons have developed with a little variations to help and to facilitate the good rhexis in their own hands. If there is no good fundal glow, we can always stain the white cataracts. If the rhexis is going to be difficult in small pupils, in pediatric cataracts, in pseudo-exfoliation, in zonular dehiscence, in pupillary membranes, in vitrectomized and silicone eyes. So these all things we will discuss in our section on difficult cataract cases. These things will come into our discussion. This spiral rhexis technique, we will also explain it, and there will be video once we have a discussion on difficult cataract management. We have already discussed a little of radiofrequency needle and femto-assisted capsular rhexis. This is another beauty, but costly machine and a whole new setup into your OT. So still it is being discussed and kind of controversial whether it can establish its role in regular phaco-cataract surgery or not. Section 3 of our discussion is about hydrodissection, and there are two verses from the same story of forbidden tree, Ishq-e Mamnua. Wahi ahwal ki pursach, so the poet has met now in a professor of the ward, not me and Professor Nadeem, some other professor of the unit has met in a corridor with whom he is talking. वही अहवाल की पुरसश, वही अलकाब रस्मी से, वही रस्मी तकल्लुम सा, वही आदाब रस्मी से. A kind of routine talk is there, nothing special. दिल ने बात की दिल से, ना आंखों ही ने आंखों से. How can somebody talk corridors of heart and eyes? दिल ने बात की दिल से, ना आंखों ही ने आंखों से. ना समझाया, ना कुछ समझा, ना समझाया, ना निकली बात बातों से. So hydrodissection is the injection of fluid under the capsular rhexis margin to separate the lens from the cortex capsule. Hydrodissection typically means separation of the capsule from the whole bulk of the nucleus and the cortex. So that's the difference between hydrodissection and hydrodelineation. Hydrodelineation is separation of the nucleus from the cortex, whereas hydrodissection is separation of the whole nuclear cortical complex from the capsule itself. So first current needs to go all around the lens matter, this whole cortical nuclear potato, and just separate the potato peel, that is the capsule, from the pulp of this whole nucleus and the cortex. That is hydrodissection. And hydrodelineation is once we use another water current to separate nucleus from the cortex. Hydrodissection is generally carried out with 26 gauge bent cannula and just going below the capsule and lifting it a little, we inject. This is very important. Just go about 1 or 2 millimeters beneath the capsule, just lift a little, maybe quarter of a millimeter, and then inject. Then it will go beautifully and you can see that current passing behind the lens as well, posterior capsule in front of the capsule as well. So that's a very healthy sign. This water current passing through all around is the first objective of hydrodissection. Once we have hydrodissection, and it's incremental, don't try to do it at a single place. And after first injection of about half cc or 1 cc or a quarter cc fluid, just tap the nucleus so that if there is any water imbibation, any fluid imbibed behind the capsule, any pocket formed, it should come up and the eye should be soft again before you are going to inject the second wave of fluid at some other place. At 2-3 places we complete the hydrodissection and then we come to the hydrodelineation. In hydrodelineation, we just dip the needle into the cortical substance and we try to separate the nucleus from the cortex. The principle is same at 2-3 places, incremental. Don't do it, try to do it in one go because it can end up in complications. There may be development behind in front of the posterior capsule and suddenly it may give way, and it is a very crucial and difficult stage to have a capsular rupture just before nucleus removal. So we need to be very careful while injecting. Don't let the intraocular pressure go very high during this maneuver. Always do it in steps. Then if we have done a successful rhexis, we can always rotate the nucleus and the phacoemulsification becomes easy. The cracking, the rotation, the addressing of the nucleus is easy job. As you see, the successful Rhexis has been completed and the cannula, 25 gauge or 6 gauge cannula, has gone underneath the capsule, and after just little lifting the capsule, the fluid is injected, and it is being injected in waves, not continuous. And once the wave is there, it goes behind the nucleus in front of the capsule, so our objective is achieved. But we can repeat the same maneuver once here, once here, once here, 2-3 places, little fluid in incremental way. This is what our desire is. Hydrodelineation is separation of the cortex from the nucleus, and hydrodissection is separation of the whole cortical nuclear complex from the capsule. And hydrodelineation is indicated more in cases of posterior subcapsular and posterior polar cataracts. We will see in difficult cataract discussions. So अब ये स्टोरी जो है ना इख्तिताम को पहुंच रही है. बेहतर है अभी सदमा दिले नाकाम को पहुंचे, बिना आगाज अफसाना किसी अंजाम को पहुंचे. तो बातचीत तो हुई कोई नहीं, तो ऐसे दिल ही दिल में रहा सब कुछ. बेहतर है अभी सदमा दिले नाकाम को, बिना आगाज अफसाना किसी अंजाम को पहुंचे. अल्लाह का शुक्र है वो कामयाब हुआ. रहे ये इश्क एक तरफा जो बेनैलो मराम अच्छा, इस किस्से का यूं ही और यहीं पे इख्तिताम अच्छा. तो जलता सूरज तनकर बोला कोई ना रोशन मुझसा हो, धीमे लहजे में एक जुगनू बोला शाम उतरने दो. So in today's discussion we had discussion on wound construction, and the closure we will discuss in next sitting inshallah. Then we had discussion on hydrodissection, hydrodelineation and capsular rhexis technique. Hope discussion. Thank you for attention. And we have 5 minutes for the questions. Tunnel जो है, it is about plus minus 2 millimeters. Yes. Dr. Akram has asked about the length of the tunnel which we construct during placement of phaco incision. That's what the square and rectangular incision is meant. Square incision means that the width of your incision is equal to depth of your incision. If your incision keratome is 2.75 millimeters, ideally you should be there about 2 to 2.5 millimeters into the cornea for the ideal depth. If it is 2 millimeter, it is rectangular. If it is 2.5 millimeters, it is almost square shaped incisions. So more peripheral you are away from the corneal center, the better it is. Freedom you have to have good depth of your tunnel. And of your keratome 30 degrees tangent to the limbus will ensure the construction of the roof and floor of your incision. The depth, the thickness of your floor and roof is equal. Viscoelastic we generally use simple methyl cellulose, and I am so used to it that even if I have viscot available for later maneuvers like coating the corneal endothelium, even viscot and provisc are there for to be used later on for IOL implantation or before nuclear phacoemulsification to protect corneal endothelium. But Rhexis I prefer to perform under methyl cellulose, because the version of that flap and the rotation of that flap is very friendly. And if you are using viscoelastic, always remember viscosity, density, viscoelastic materials, this version of the capsular flap and feeling of the capsule during your maneuver will be different. Then don't get confused and don't get tense, because whatever fluid, whatever intraocular viscoelastic you use, the interaction of your needle with the capsule will be a little different. So be ready for that. But generally methyl cellulose. Only in hypermature cases we recommend to use heavy viscoelastic.
What is the advice to the beginners if he or she starts this and do not complete it? Then
So Dr. Naeem is asking about advice to the beginners that they are starting the Rhexis. The first thing is that don't try to go through your main phaco incision to begin with, because main phaco incision is about 2.75 to 3 millimeters in size. And the second thing which I will incorporate in my slide is, which I keep on discussing, but today I forgot to stress it, that is to use lip as fulcrum. You understand the fulcrum? The fulcrum is a kind of concept of lever. In physics books, we used to study what is the principle of a lever. It is a kind of bar which keeps on moving on a certain pivot, central point. That is known as fulcrum. So once your needle is there, the tendency of the beginner is to depress the whole complex down. No, this is not you need. What you need is, if you want to dip your tip, raise the outside part. If you want to lift your tip, depress the outside part. Don't depress your incision. That's what I mean. Keep your incision lip as a fulcrum and keep on moving by external limbs of this needle will generate the movement inside. Don't move like that. Don't move like that. So that's the kind of first thing. Second, enter through the side port incision so that the chamber doesn't collapse again and again. And have a separate stab incision for your completion of your Rhexis to begin with. And keep your anterior chamber deep, and you can practice with potato peel as well. So with this we come to an end. Thank you very much for your kind attention, and hopefully we will meet next week with our next discussion that will be on nucleus and cortex removal, and we will be again discussing few points which we missed in today's discussion. We will revise it again, and you can always come up with questions even from our previous discussions. Thank you.